right. Hi, everyone. My name is Ikjot Singh. I'm a third-year medical student at New York Medical College up in Westchester. Today we're going to be discussing this article called Resective Surgery Prevents Progressive Cortical Thinning in Temporal Lobe Epilepsy, written by Galovic et al. In 2020. So let's get started. Okay, so just a little bit of background first. Recent emerging evidence has shown that epilepsy is a progressive rather than a static disease. So classically, it was sort of thought of as an electrical focus, which can result in seizure activity, but it's been shown that it has actually widespread parenchymal effects as well, bilaterally on the cortical side of the brain. And this suggests that there are some underlying different neurodegenerative processes that are going on. And one key thing is that there are aberrant physiological changes that occur even outside of the focus of the epileptogenic focus. And this is associated with a greater rate of cognitive decline. In refractory cases, it has been shown that there's actually an increased cortical thinning that's more than twice the rate that's found in patients that's caused by normal aging. And anti-epileptic drugs have been shown to not modify these long-term pathological changes. They merely treat the symptoms of the disease. So in refractory cases, one of the procedures that can be done is an anterior temporal lobe resection that's indicated for refractory cases. And this has been shown to actually decrease or even stop the seizures and also slow the underlying pathological processes, which have not been fully elucidated, but it's been shown to have an effect on that. And one of the things is that there's often a prolonged delay between the point of the refractory diagnosis to the point of the surgery. And so one of the ideas is that, why can we not offer this earlier to select patients to intervene sooner and prevent some of the neurodegeneration that occurs? So the research question, this study was actually based on a previous study by the same author in 2019 that essentially showed that global cortical thinning is seen as a consequence of focal epilepsy. So epilepsy causes cortical thinning. And this was done using MRIs to show the neuronal loss and neurodegeneration. And they used a lot of computational analysis that we will touch on briefly. And so essentially this identifies the neurodegeneration as a therapeutic target to disrupt or slow this ongoing atrophy. And so the hypothesis is, does epilepsy surgery prevent further progressive neurodegeneration in refractory focal epilepsy?
Okay, thank you, John. Thank you. So for the methods, the authors designed a prospective cohort study. They selected their patients from an already established MRI data set by Jane DeTisi and her team. So that was comprised of pre and post-surgical scans of epilepsy patients at one specific center. This study had 209 patients, 85 of which were from that previously mentioned study, from that data set, while the rest of the 124 were controls. So the inclusion criteria were the following. So the patients had to have at least have TI MRI scans at least 6 months apart. The patients had to have had their surgery done by one single neurosurgeon with initials AWN, and each post-surgical patient should have at least 1 year of post-op follow-up. So the inclusion criteria consisted of just having no active neurological conditions such as stroke, and the authors didn't want to deal with any MRI scans of poor quality. In regards to the controls, those controls they came from 3 differently publicly available data sets from a totally different team. And each data set was different from each other. And the only criteria that they had to follow is that they had to at least have the imaging 6 months apart. So I'm a very visual person, so I kind of just made this kind of graphic to visualize the entire process. So like I said, there's a bigger original data set of which they picked 85 patients and then 124 controls from a different data set. So I just wanted to make it clear that they were comparing a pre-surgical group versus the post-surgical group. Those were 2 independent groups and instead of a paired study. So what I mean is in the pre-surgical group, we'll see that there's 29 patients in that group. They didn't have an associated post-surgical scan with that. It was just kind of very independent. whereas the post-surgical group had 56 patients in that group. And again, they just didn't have this, they're just not related. So important to know, the pre-surgical group had a mean interval scan of 28, whereas the post-surgical group had a mean interscan interval of 14 months. So noticeably, the pre-surgical interval scan was longer. It is worth noting that 8 patients in each group were actually paired, but it's just a minor thing. And then it was this data was analyzed. So like I was alluding to before, there's 3 groups: control, pre-surgery, post-surgery. And the pre and post-surgery was further divided into a left surgery or a right surgery. And by surgery, I mean the anterior temporal lobe resection. And 2 things were basically measured. They looked at baseline characteristics and morphometric data. In regards to the baseline characteristics, it was just your characteristics like gender and sex. And what the authors were trying to determine whether or not the 2 independent groups were they different? Was there any inherent bias? And we didn't have a dedicated slide, but the authors were able to prove that there was no inherent differences between the pre and post-surgical patients that would add to any bias. So the main crux of this project would be the morphometric data. So here they're using an automated kind of subroutine that determined cortical thickness. This cortical thickness was measured at pre-chosen regions of interest, random parts of the brain, and they compared that with the controls, with the pre-surgical groups and the post-surgical groups. So here I just wanted to briefly mention, because this is a little complicated, but I thought it was very interesting worth delving into and at least appreciating. So we have the raw pre-surgical scans and post-surgical scans. Before we can use this subroutine to measure any inherent differences of cortical thickness between the pre-surgical scan and the post-surgical scan, the computer we need to make sure the computer doesn't confuse any potential resection as a difference due to cortical thickness. So what they had to do is to make sure the computer didn't misattribute any differences to the resection itself. They put a patch over the resection, essentially a Band-Aid. So it would camouflage any issues with the actual resection area. They would put a bandage, they would dilate that up past the margins of the resection to make sure the computer, the program wouldn't see that as a potential difference. Then they were spatially oriented in each other's space so that if you picked one point in the pre-surgical image, it would correspond to the same structure in the post-surgical image. And then that was further analyzed and for the study. I think the only thing I wanted to highlight is that they did something called dice coefficients, which is a measure to validate the pre-processing or the spatial registration. So you're able to prove statistically that through this process that they didn't note any differences when they through this normalization process. So essentially they verified that what they did was not inherently biased, there was no mistakes. So next slide.
Okay, so I'm going to be discussing the data, and just before I dive into this, just want to mention a couple things. So the results showed that the affected areas were bilateral and were spread beyond what is considered like a classic focus, which actually reinforced the concept of epilepsy as like a network disorder, which affects widespread areas of the brain. And one of the proposed pathophysiologies that they underlied, were excitotoxicity, metabolic stress, inflammation, and cell death. So compared to the healthy controls, on the left and right, pre-surgical patients showed accelerated thinning. This was established by Galovic in 2019. And one interesting thing was that the pre-surgical cortical thinning in the left and the right patients was not associated with seizure frequency, which was an interesting point. And so if we look to the graph on the left here, we can see that, so these are regression analyses done, where they basically, fix lines of best fit to show the trajectory over time of the cortical thickness in these patients, and they normalized or equalized the y-intercept as well to show this. And so what we can see is that the healthy volunteers are the gray line, and so those healthy volunteers are showing a rate of decline that's consistent with normal aging. And if we look at the pre-surgical patients on both the left and the right graphs, you can see that the blue line is, a drastic decrease in cortical thickness. So they're projected to lose, a lot of mass in their brains over time. And if we focus on the left side now, we'll see that the post-surgical patients, which is actually the orange line, brownish line, those patients actually did show a greater cortical thinning compared to controls, but this was still far less drastic than the pre-surgical patients. So as you can see the difference between the blue and the orange. And one interesting finding actually was that in these patients on the left side that had the resection on the left, there was actually cortical hypertrophy in the right supramarginal area and the right superior parietal lobe. And one of the proposed mechanisms for this, hypertrophy is that it could be compensatory, so that over time the epileptic focus was actually causing, deleterious effects on the parenchyma. And now what's happening is that once you remove the epileptic focus, it's actually normalizing, and there's actually some structural restoration that's occurring in the area. So that was interesting as well. On the right side, the atrophy that was shown had no significant difference at all from the healthy control. So this is a very promising sign. As you can see on the right side, there's almost no difference between the orange and the gray lines. And one last thing was that the post-surgical cortical thinning on both left and right resections was not associated with resection volume, which is also interesting. So also one thing I want to highlight now is that there was actually some laterality that was noticed. So in patients who had a left resection, basically pre and post-surgery, they had decreased cortical thinning in many areas of the right hemisphere. And this also was sort of suggestive of a restitution of the normal cortical structures on the contralateral hemisphere, and that may have been pre-surgically affected by the epileptic activity. So basically the left focus is causing changes on the right side, and that now you're removing that epileptic focus, and now you have improvement in the right side. On the right, when the surgery on the right side, you had pre and post cortical thinning in the right paracentral and postcentral areas, as well as left anterior insular cortex. And as Sid mentioned earlier, there was a paired analysis in which we had 8 patients who had actually pre and post-surgical MRI scans. And so this removed a lot of the confounding variables because we're using the exact same subjects. And so in these patients, the results were consistent with the larger group, and it showed decreased thinning in the right side in the supramarginal gyrus, precentral gyrus, etc. And there was some worse thinning in the left supramarginal gyrus and left superior temporal gyrus. So that was interesting. Okay, so now on this slide, we're going to be comparing the outcomes. So basically, compared to the controls, patients who were actually non-seizure free after the surgery, they still showed more progressive cortical thinning. And this was significant. And one of the mechanisms proposed was that perhaps during the surgery, there was some failure to remove the entirety of the epileptic focus. And so there was still some leftover, remnant areas of the temporal lobe that were still causing some, epileptic signals that were still maintaining the, the atrophy. And in seizure-free patients after surgery, there was actually, it was shown that there was no difference in atrophy at all. And so this was also a promising sign, is that these patients were completely seizure-free after the surgery, up to 1 year. And they had no difference in atrophy as compared to healthy volunteers.
Okay, so just kind of the discussion. So the key takeaway and the novel finding for this paper is that cortical thinning was significantly lessened after doing the surgery. So one of the findings that Ikjot was noting a lot is that there's some laterality found by, regardless of what surgery you did, there was some very significant observable effects on the right hemisphere. And it seemed interesting, even if you did a left surgery, a left anterior temporal lobe resection, you would see such interesting or one-sided effects on the other hemisphere. And the idea is that because you're doing left surgery, the left temporal lobe houses eloquent cortex. And by alleviating whatever epilepsy focus that's happening there in that specific network state there, it might be allowing for structural compensation, allowing for plastic changes happening on the right. So it's just an interesting thought. So the main paper it wants to talk about is that doing a successful temporal lobe surgery, a class 1A outcome where there's no seizure 1 year post-op, has an apparent neuroprotective effect and may prevent ongoing neurodegeneration. So some limitations, just to quickly go through. The findings only apply up to the first year of post-op of standard anterior temporal lobe resection. So we don't know what happens after the first year. Do these results maintain or does it change? So that's something that the paper notes. Healthy controls are extracted from 3 independent public data sets. Would have been better if it was within the same data set. The pre-surgery and post-surgery groups were analyzed as 2 independent groups. So the paper does acknowledge that a paired study would have been better to kind of alleviate any potential bias or confounding events. And the other thing they noted was interesting is that the patients were still taking their anti-epileptic drugs. So it's part of standard of care to continue taking those medications 1 year post-op. So they weren't able to determine whether or not what effects there would happen once the patients are off their medications. And this was a single center study with a small sample size. So possibly in the future, they could expand their numbers and see if there's any other variation or anything they could see as they have a bigger sample size. And lastly, pre-processing and masking was necessary to ensure scans would be compared for analysis, but it also adds a little limitation because you have to go through that process and there might be some question of whether or not there might be some bias through it. But yeah, that's kind of our presentation. Any questions?
Thank you both for that. That was a great talk. I really appreciated the outline that you made. Being a visual person myself, I found that helpful. So I encourage the audience to please put questions in the Q&A section or in the chat. And I think we have time maybe for 1 or 2 questions before we transition to the next group. So Siddhatha and Ikjot, there's one question here in the chat. Is the cortical thinning in all cortical regions / lobes, or is it specific to a certain region? And I assume they're talking about kind of in the pre-surgical group, what the natural kind of pathogenesis of it is.
They kind of saw a global cortical thinning, both on the left and right side. There wasn't necessarily a preference. I think because with this analysis, they pre-chose all the regions of interest. They didn't necessarily look at every specific area, but they had areas in mind when they were doing this analysis. But with the areas they chose, they did a good job trying to figure out if there was like laterality in the pre-surgical group beforehand. And based on the paper, it just seemed like there was just a global cortical thinning, both on left and right side.
Great, thank you. And there's one more question that we'll take. Did the authors postulate a reason behind the absence of hypertrophy on the left side versus the right side after resection?
I don't know if Ikjot, if you remember, I don't think they did postulate a reason why there was hypertrophy or any thickening. I'm trying to remember, but.
Yeah, they proposed the mechanism of the compensation, but I'm not sure why, or I don't think they postulated any absence or like mechanism behind the absence of hypertrophy on the left side. So that's definitely something worth looking into, and we'll definitely look into that if there's any mechanism there.
Yeah, that's great. So just in the interest of time, why don't we move on to the next group, which is Olivia and Andreas, and I think Olivia is going to be the one presenting for us today. And the paper that Olivia is presenting is on language network reorganization after temporal lobe epilepsy surgery, which should be very interesting from a neuroscience standpoint.
Yeah, hi guys. So my name is Olivia Gilbert. I'm a fourth-year med student at LSU in New Orleans, and I'll be presenting on the paper that Michael just introduced. It's a study published in July of 2020 by JNS, by an epilepsy group in Vienna. Just for some background, what is drug-resistant epilepsy? We kind of heard a little bit, and from Dr. Benheim last week as well. DRE is defined as a failure of 2 tolerated and appropriately chosen anti-epileptic drug regimens. An estimated 30 to 35% of patients with epilepsy have drug-resistant disease, so it's pretty prominent. And uncontrolled disease leads to seizures that can cause significant harm to the patient and ultimately lead to cognitive impairment, especially those impairments in language and memory domains. So what do we typically do about it? Epilepsy surgery is a very commonly used intervention that can offer up to 80% seizure freedom in these patients, but it comes with its own risks, and those risks can entail language deficits as well. There have been a few structural imaging modalities that historically have been used to look at brain activation in temporal lobe epilepsy, or TLE, but the two here are DTI and fMRI. The authors mentioned in the intro that these are pretty limited in fully explaining the neuropsychological profiles in surgical TLE patients, as they're only limited to structural analysis, but they're still useful nonetheless. And then fMRI functional connectivity analysis is another modality that complements the pre-surgical language mapping. We'll dive more into these methods and how they work shortly, but I just wanted to introduce them briefly here in the background section. So with all of this in mind, the principal aim of the study was essentially to use functional and structural imaging to investigate the neural architecture of language function in drug-resistant temporal lobe epilepsy patients before and after surgery. And by doing a double time point study, we're able to look at both the pathology-driven or the temporal lobe epilepsy-driven language organization, as well as the surgery-triggered language organization, and also all the while considering those structural and neuropsychological measures. So how did they do it? The final study was comprised of 28 patients, 16 right and 12 left temporal lobe epilepsy patients who were retrospectively screened for the presence of a pre-surgical fMRI, and then who subsequently underwent partial temporal lobe resection, and as well as post-operative imaging. And they also picked 22 healthy patients to serve as the controls who also underwent the same imaging to compare to. So in order to understand the results, I think it's really important to grasp how the imaging measurements they use work and what exactly they are designed to demonstrate. At least for me as a medical student, I had little understanding of these methods before reading the article, and so I thought it would be beneficial to explain them in more detail. The first one that they used is activation mapping. This is just like what we see with an MRI with bold signaling. So bold is the oxygenation response. It's kind of like an oxyhemoglobin and deoxyhemoglobin spin reaction when you have an MRI. So there's a really unique bold signature where the signature itself has a higher amplitude when you have higher metabolic demand or higher activity. And there's a slight delay in terms of seconds, but it's essentially what activation mapping is. And the image here is just showing an example of bold signaling in different locations of the brain. The second measurement tool is DTI and fractional anisotropy. And when I think of FA, I think of this example. So if you take a stream of water and then you put a 1 inch by 1 inch by 1 inch cube somewhere in the stream, and you look at the water that's passing through that cube, you can measure the velocity of all of those moving water particles, and they're all going in one direction. So the FA of that 1 by 1 by 1 cube would be close to 1, or basically everything's going in one direction. But if you take the same cube and you put it in a lake where there's not much flow, or maybe there's some going here and some going there, but there's not really many currents, the FA of that same cube would be 0. And in the brain, we can imagine the ebbs and flows of information. And so the FA in the brain is a measure of the average direction of the axons in a region of the brain. So it naturally applies more to white matter than gray matter. It's also dependent on the Tesla power of your scanner, because the smaller you can make that cube, the easier it is to determine the overall direction of the connections. Also, if you think of an axon that might be in an L shape, for example, the FA of that would be 0 because there's 2 perpendicular lines in that cube, but there's clearly an axon coming in and out. So the downfalls of this method are made up for in functional connectivity, which we'll get to that in about 2 slides. So this method is super simple. They essentially took the concept of slide 7 with the activation mapping and assessed bold signaling in what we perceive and what we call as Broca and Wernicke's areas. And they said, basically, is there more signaling on the left or on the right? And essentially they're asking which one is the more dominant side. And then finally, the last measurement tool is the functional connectivity, or the undirected correlations between regions. So if you look at the different areas of the brain and you see what the bold signature is, and then you look to see how correlated it is in space and time using a Pearson correlation coefficient, or an R value, and that gives you the FC values. Moving on to results, this is figure 1 of the paper and one of the overall key findings. It shows that after surgery, patients with left TLE underwent extensive remodeling to the affected areas. Specifically, they found decreases in left inferior lobe activity and increases in right anterior lobe temporal activity. Also of note that most of the TLE patients had bilateral frontal language dominance in the post-op scans versus the pre-op scans where they were mostly left-sided dominant. And to me, that makes sense because if they were left-sided dominant before surgery and we resected that particular area and some of its connections, they'd want to remodel and strengthen the already existing connections to the contralateral side, as opposed to the right TLE patients who had decreased activity in the right inferior frontal lobe, but increases in the right dorsal insula and anterior temporal lobe. So there weren't really any changes to the left-sided activation. I think that might have been because it was dominant preoperatively already, so it wouldn't naturally change with right-sided resection. But overall, I think the changes in the left temporal lobe epilepsy are a little bit more severe than the changes in right temporal lobe epilepsy in terms of reactionary activity changes that we're able to see in the images that they took. So the functional connectivity changes, first, please note that they switched left and right in these images. So now the left on the screen is not the patient's left like it was in the last one. So now it's true left. So compared to controls, the left-sided TLE patients had increased connectivity. So now we're looking at connectivity when it comes to these medial connections versus the right side TLE patients who had more lateral widespread connections. You can see that in the left 2 images there. And then the middle 2 images, when you look at the postoperative results, there are obviously going to be a lot of changes between the surgery patients and controls. And then the right 2 images, finally, it's the pre to postoperative comparison that highlights left hemispheric FC decrease and right hemispheric FC increase in left TLE, which that's the same thing we kind of captured in the activation mapping, while right TLE showed more of a mixed picture of frontotemporal FC alterations. I think the main clinical implication of this analysis is simply that temporal lobe epilepsy and resection surgery causes widespread changes in functional connectivity. I'd be really interested to hear Dr. Raslin's perspective and conclusions from this analysis. And then lastly, when looking at the language functions that they tested, it was only limited to 19 of the patients, and they didn't separately analyze right and left TLE, but they found that naming and semantic fluency tended to stabilize or return back to baseline postoperatively, while phonetic fluency, which is kind of the ability to name and articulate words that are somehow already linked in sound, somehow improved at the group level. Additionally, they found that preoperative contralateral contribution of language areas is a good prognostic factor for post-op language ability. But again, these results are limited because they were dichotomized, they weren't available for all the participants, and the time frame also varies substantially for these analyses. In conclusion, I think there are characteristic remodeling findings in left and right TLE that can be analyzed successfully using functional connectivity. And also the right TLE patients, they found that they tended to undergo more subtle language network reorganization than left TLE patients. And this is consistent with other studies that have shown activation mapping is not much different between left and right TLE patients and controls, but overall connectivity is markedly different and may relate to subtle language difficulties. And then lastly, preoperative contralateral contribution of language areas is a good prognostic factor for postoperative language ability. I think there are quite a few limitations to this paper. I don't think they answered a very specific clinical question, and there was also very limited statistical analysis, but I have a lot of limitations here, but overall, I think in the future, if we can keep refining these imaging modalities and create more studies with more sample size, better power, we can look at their clinical use. But more importantly, we need studies that answer more specific clinical questions. So maybe one's looking at the extent of resection or outcomes in patients with certain functional connectivity findings that might guide surgical extent or timing. That's all I had. Thank you so much. And I'm happy to attempt to answer any of the questions that you might have.
Thanks, Olivia, for that and for taking on the presentation yourself. It was great. And definitely, if you can, just send an email afterwards with that question that you requested from from Dr. Raslan that you would like to have answered, and we can make sure to get that to him and get you guys connected. Again, anybody that has questions, please put them in the chat or the Q&A, and we'll take maybe 1 or 2 questions before we get to the final group. So maybe just one I had, which is one of the limitations that you brought up, was the kind of role of language as a very complex skill that varies with a lot of personal factors and a lot of interperson variability. Did they mention, if there were any, if they were able to analyze anything like that, looking at different factors between the patients, or was it more just bulk analysis?
I think it was mostly bulk analysis, but the limitations that I was mentioning there were mostly things like medications and education level. And the authors mentioned in the language part of the analysis that they had to dichotomize the results based on, they had limited availability of the results. And so since they had such low sample size and that they had not enough surveys inputted into their database, that they really didn't have enough statistical power to do any type of, really thorough analysis. And so it was limited on that. And then also, like you mentioned, and like you asked, language is a very complex function that we are able to do. And they really didn't have the capability to look at the baseline variance of fluency and things like that.
Awesome, thank you. Yeah, we would definitely look forward to seeing future analysis with some subgroup analyses included. So why don't we go ahead and have the final paper presented, which will be Andy Wang and Doi Fan. And again, I apologize if I mispronounce the name. And what they will be presenting is a recent paper looking at the clinical utility of intraoperative electrocorticography in pediatric epilepsy surgery. And this is definitely a growing area of stereotactic and functional neurosurgery, doing this intraoperative recording that I believe Dr. Mew actually talked about in her first session. So without further ado, Doi and Andy, please take it away.
Thanks, Mike, for the opportunity. I'm Zui. I'm an MD PhD student at Yale. I'm in my 3rd year of medical school now. Happy to present, and let me share the screen, and then so I will be going first, and then my co-presenter Andy can take over. Does that sound good, Andy?
Sounds great.
All right. All right, okie doke. So I thought it would be, so this concept has already been sort of discussed many times, but basically a goal of epilepsy treatment, particularly for drug-resistant epilepsy, is localization of the epileptogenic focus, and then resect that region to basically prevent further seizures, and hopefully with minimal neurological impairments if the eloquent cortex is spared. So the topic of, so this is sort of kind of 50,000 foot view of how I think about this, where patients will start with drugs, they become resistant. And so then there's this pre-surgical evaluation to look for where the seizures are coming from. This can be done by long-term video EEG monitoring in the epilepsy monitoring unit. And then for more precise delineation of the seizure focus, we can do intracranial EEG. So what is the role of intracranial EEG in epilepsy? Well, so here's a schematic from a study, sort of basically at a conceptual level, we think of the epileptogenic zone as sort of the region that causes epilepsy. But the hope with intracranial EEG is that if we can catch a seizure when it happens, we identify the ictal onset zone. And then surrounding that is this EZ. And then even further surrounding that are sort of these irritative zones that show some sort of interictal activity. So basically with preoperative ECoG sort of long-term several days, we hopefully catch a seizure, try to define the surgical margin, and then we can do intraoperative EEG to actually look at the interictal activity and potentially modify the surgical margins based on whether do we see more interactivital activity surrounding this epileptogenic focus. So the question that the paper that I'm presenting tries to answer, really broadly speaking, is what is the clinical utility of intraoperative EEG, especially for the pediatric epilepsy patient population? So number one, what is the effect of using ECoG on seizure outcome and complication rates? Two, what is the effect of epilepsy and patient-related variables on ECoG-guided surgical strategy? And three, what are the predictors of epilepsy surgery outcomes? So the design is a retrospective study. I apologize, this is a little bit busy, but basically what you need to know is that they consecutively looked at all the pediatric patients who went through their epilepsy center. All of these patients had drug-resistant epilepsy who underwent a traditional panel of pre-surgical evaluation with scalp EEG, structural MRI, and followed by intracranial EEG. So basically 141 patients were included in the study, and they were categorized into three groups. So the focus is on, okay, what is the utility of intraoperative ECoG? So this is basically at the time of surgery, right before they're actually just determining whether to, how much to resect. And basically, so they already know the epileptogenic zone, but should they basically resect more? So in the first group, they do not basically, these patients, they did not detect any abnormal ECoG activity beyond the predetermined margin. So no modification to the surgical plan. In groups B and C, in these groups, they found abnormal ECoG findings beyond the surgical margin. And so the plan was either modified or not modified. And based on that, among these three groups, they wanted to compare what is these outcomes of the surgery and complication rates. They also performed a multivariate analysis to identify predictors of outcomes. At this point, I'll turn the slide over to Andy. I'll start sharing.
Actually, do you mind just sharing it for me?
Oh yeah, sure.
That'd be wonderful.
That would've been, I'm sorry,
Thank you.
should have done that.
Just to keep it a little easy. I'll just tell you when to go next.
Yeah, yes, sure. Give me a sec. Yeah, all right, here it is.
Great, thank you so much. So next slide. I'm Andy Wang. I'm a fourth year medical student at Tufts. And just to continue, let's make sure that we remember what these letters are because we're going to be using the groups. So group A was when pre-evaluation determined the surgical resection plan, and ECoG monitoring ended up not needing any more changes. So group A is just going with the original plan. Group B is when you had to modify the original plan because ECoG showed that there were additional areas that could be resected. And then group C is ECoG showing more areas that need to be resected, but the surgeon could not because it was close to an eloquent area or it was not feasible. So just remember, A is the original plan, B is modified, C is should be modified, but could not be.
Wait, sorry.
No worries.
Sorry.
Okay, great. Sorry, could you go back one slide?
Yeah.
So like I said, group C is the patients that needed to be modified but couldn't. And the result was that they had a lower seizure freedom when compared to A with the original plan. That makes a lot of sense. It also has a lot lower seizure freedom compared to B. And A and B did not differ. So whether the original plan was followed or if additional resection was continued, they both had equally good outcomes. However, group B had more frequent complications than A. So that was a main finding, but they also noted that the characteristic of these more frequent complications tend to be minor. So they weren't major complications, but they were more minor complications, and they defined this as a duration less than 3 months, as well as not affecting daily life. It's a little bit of a vague definition, but those were the two criteria. But there were no difference in major complications. Next slide. And it was really interesting that they actually came up with what factors could affect whether someone needed modification or not. They basically found through multivariate analysis that what determined whether a person could need modification are increasing age, MRI negative findings. So basically they couldn't find the epileptogenic zone on MRI, as well as the presence of intellectual disability and daily seizures, so kind of worse symptoms. And this is really important because this shows the type of patient where ECoG could be useful. And I think what seemed maybe obvious to med students, but is actually not, is the utility of ECoG. It really is disputed. We're not still sure whether it's good or not. There have been papers disputing whether it's beneficial for epileptic surgery or potentially harmful. So it's actually up in debate, and that's what this paper is trying to answer. Next slide. So they also used multivariate analysis to find what factors helped predict better outcomes at 2 years follow-up. So they found that the type of histopathology, the type of disease that they had, whether they were able to achieve complete resection or not, whether it was an MRI negative finding, as well as the ECoG group. And they actually found that the best results were patients with in group B, where they required modification of the original plan, but managed to get a complete resection. And they, again, made these beautiful charts kind of emphasizing each cohort and each factor. Next slide. So discussion in this paper, they were trying to answer whether ECoG intraoperative monitoring really affects complications and whether it's helpful. And they did show that it does increase the rate of minor complications in group B when you have used it and actually need to extend the resection. But they were also able to identify the risk factors for who might benefit, the risk factors for increase of seizure freedom, as well as the probability of a worse outcome, namely those with a normal MRI and an incomplete resection. And their big takeaway is C had worse outcomes than A, as well as one note that in patients in group B who had extended resection, all the pathology showed original pathology. So basically showing that the resection took out what was supposed to be taken out. Next slide. In conclusion, some limitations of the study. It's a retrospective study. It's not a RCT. So basically they weren't able to actually test whether ECoG itself was a factor. It's all correlation. The patients weren't randomized. There wasn't a control group for ethical reasons. The population was heterogeneous. They just had to take what patients went through. And they actually couldn't measure if the ECoG procedure itself had any effect on the epilepsy surgery. So kind of whether this procedure itself had any harms. It's thought that it's pretty benign, but there needs to be more studies really elucidating that effect. Next slide. So in conclusion, and you can just press all of them, they show that the intraoperative ECoG is a reliable tool to guide resection and actually may help inform prognosis. So namely that group C patients would do worse. And surgeons would not know this otherwise if they hadn't done ECoG. And they showed that modification, which is talking about group B, achieved greater seizure freedom than in those whom modification is not feasible. And lastly, they really came up with some important factors to consider for predicting those that might need modification and therefore might need ECoG more than others. What factors leads to better seizure freedom and what factors may lead to unfavorable surgical outcomes. And that is the end of our slides. Thank you for listening and let us know if you have any questions.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.